So I'm going to talk about proximal junctional kyphosis and proximal junctional failure. There's kind of two ways to describe this problem, which isn't necessarily thought of as two different problems, but I'll sort of provide definitions. We've moved from one terminology, PJK, to PJF for a lot of this, and I'll describe what that means. These are my disclosures, and they aren't. I'm not going to really touch on anything that's in that. They're also in the book. So I'm going to go over a case and then talk about some of the evidence in the literature and some thoughts on avoidance. And really, all of this is to generate a discussion about what to do. And I'll start with this case of a 59-year-old woman with prior history of L4 laminectomy, recurrent stenosis, and spondylosis, spondylolisthesis, who ultimately underwent a multi-level laminectomy, interbody and posterior fusion. I believe these were A-lifts and posterior fusion that she'd had. At any rate, about 2 years post, she had adjacent segment degeneration and underwent an additional adjacent surgery, and then about 18 months after that was referred to us for recurrent adjacent segment degeneration and progressive kyphosis. And so I thought, looking at this, aha, I've got the answer, and removed those top screws, straightened her spine out, and had her standing much straighter, and she was very happy. Still a bit of sagittal balance, not quite right, but much better for about a year. And then she developed that. And I'm really good at creating that, I think. So let's talk about proximal junctional kyphosis. The definition is postoperative change in the proximal junctional angle, which is the angle between the upper instrumented vertebrae, the inferior plate upper instrumented vertebrae, and two vertebrae above that, the superior. So that if that change is greater than 10 degrees, that is the definition. It was in this paper in Spine in 2005. This is the paper, and it came out of the WashU group, and talked about the incidence and the problems, and the fact that this hadn't been mentioned much. And in fact, there was about a 26% incidence, and the risk factor at that time they thought was when the upper instrumented vertebrae was in the upper thoracic spine. And fortunately, it didn't seem to affect outcome scores, but nonetheless was something that we should be watching for. Then came Kim's two papers, this one and the next, which actually showed an increased incidence of proximal junctional kyphosis at about nearly 40%, and showed that most of those actually occur in the first 8 weeks. So it's a pretty quick process. Again, no difference in outcome scores, they thought, but we started to see what risk factors. We started to understand maybe there were some elements of a patient's anatomy and or problems in the way we treated a patient, either modifiable or non-modifiable risk factors that led to this. Age, not modifiable, but osteoporosis, maybe. Fusions to S1, maybe modifiable, maybe not. But those seem to be the biggest risk factors. And then the group out of New York with Boachi, again, talked about proximal junctional failure, a little bit lower incidence at about 20%. Again, no difference in outcome scores, but really talked about global sagittal imbalance, particularly preoperative global sagittal imbalance, as a risk factor. So we see patients all the time that have global sagittal imbalance, and we're worried about postoperative proximal junctional failure. And then out of the same group, and Yagi really, I think this is one of the bigger contributions, is to start separating different kinds of kyphosis, because they're really not all the same. This radiographic PJK, which is really an angular change noticed at the top of the construct and above, is really a different beast from fractures of the upper instrumental vertebrae or fractures of the UIV +1 with listhesis, which we'll see. And it's this symptomatic PJK, the ones where there's fracture, hardware failure, or both, that are really the problem. Then the same group looked at their 5-year minimum follow-up and noticed that almost 3/4 of PJK occurred within 3 months. And now we're starting to see risk factors of osteopenia again. This incidence, again, is about 20, 22, 25%. But when they have this symptomatic PJK, it's the first time we've seen this, their patient-reported outcome scores actually are starting to be different. And we're actually looking at a different group of patients than simply the radiographic measure of mild kyphosis at the top of the construct, but rather this fracture hardware failure group And we see either supraadjacent vertebral fracture, or we see this fracture at the top, the UIV, plus a subluxation. And this second group actually will sometimes even see myelopathic changes and neurologic injury associated with this. So before I move to this concept of proximal junctional failure, let me just summarize PJK. PJK is a definition of an angle of the upper instrumental vertebrae to two above of a 10-degree change from pre to post-op. The incidence is around 20 to 40%. It often occurs early in patients that are over 55, osteoporotic, that have anterior and posterior fusions, and sagittal plane deformity. Many are not symptomatic, particularly this ligamentous kind without osseous changes. And the ones that do have osseous changes may go on to myelopathy, and we need to pay close attention to that. So that's proximal junctional kyphosis. Starting about 6 or 8 years ago, we started looking at something, say 6 years ago, different than just PJK, and that is proximal junctional failure. And there was a little bit of a competing terminology for a little while, but I think we've settled on what that terminology is. The definition of proximal junctional failure is symptomatic PJK, and by symptomatic, the patient is increased back pain and worsening patient-reported outcome measures due to upper instrumental vertebrae or UIV +1 fracture or hardware failure, or both, and or new onset myelopathy. And this Hostin and the International Spine Study Group really have pushed this concept forward. And this is the paper that really sort of helped define this. PJK of greater than 15 degrees, proximal junctional fracture, instrumented failure, and need for revision within 6 months as the definition of acute proximal junctional failure. And the incidence they found wasn't that high in their registry, about 5.6% of all comers. But we started looking at this in our group, and we have a series of papers, our studies out, and you'll see that our incidence is much higher. And then we focused on some of the risk factor groups in particular that probably have led to this. One of them in particular is patients over the age of 55. So we looked at all the patients that we'd been taking care of over the age of 55 with adult deformity surgery. And we had 165 patients with minimum 1 year follow-up, average 2.5 year follow-up. And in that subgroup, we found a significant increased rate of proximal junctional failure. And we split them up by where the upper instrumental vertebrae was, whether it was in the upper thoracic spine, lower thoracic spine, or upper lumbar spine. And we found the highest incidence of acute proximal junctional failure in those patients that we stopped the upper instrumental vertebrae in the low thoracic spine. And it most often was secondary to a fracture, although we sometimes also saw implant failure and occasionally new onset myelopathy. Now we looked at early revision surgery, and we found that this occurred in about 10% of that entire group, but 37% of patients with acute proximal junctional failure. So the early revisions were almost always all the patients with myelopathy had early revision. 75% that had implant failures had an early revision, early again being within the year that they had their index surgery, and about a third of patients with fractures. And again, most of those occurred in the low thoracic and upper lumbar spine, not so much in the upper thoracic spine. So even though that initial paper out of WashU said risk factor for PJK stopping at T3, it was really the failure and the revision surgeries that occur when we stopped in the low thoracic and upper lumbar spine. So we're starting to question our decision making. Are we stopping at the wrong level? And if we look at some of the articles in the literature that help us, we couldn't quite figure out if that was the case or not. And this is the one that I've often quoted, and again out of the St. Louis group. They looked at upper instrumental vertebral levels of T910, 1112, and 1-2 to try and see if there were failures that were more likely at any of those levels, and there weren't. In fact, the incidence of PJK was the same, essentially statistically the same, at all three groupings, although there's a trend towards lower incidence in the upper lumbar spine. And the incidence of revision was essentially the same at all three groupings as well. So stopping at L1 or T12 or T11 or T9, T10 didn't seem to change the incidence of PJK or the need for revision. So this implied that there was no difference between those groups, and we wondered what other factors might lead to the incidence. Is there predictive factors that we could identify? And we found two in a multivariate regression analysis of our patients. One was a lumbar lordosis change of more than 30 degrees. And the other was a postoperative proximal junctional angle of more than 5 degrees. I'm going to go through those again. So if we change lumbar lordosis by more than 30 degrees, the incidence was much higher. The risk was almost 7 times more likely that we would get a proximal junctional kyphosis than if we'd changed lumbar lordosis less. And so that pretty much includes all of our osteotomies. And secondarily, if we stopped at a level in the low thoracic spine in particular, where the proximal junctional angle was more than 5 degrees, then the risk of failure was greater as well. The odds ratio at 27 times. So lastly, we tried to figure out what was going on with where we stopped. And we started looking at this low thoracic versus upper thoracic stopping point, as I'd mentioned 2 papers ago, and found that the low thoracic stopping points seemed to generate a lot more proximal junctional failure. And in fact, as we were looking at our data, it seemed like when we stopped at T10, which is the common place to stop for a lot of people, kind of standard, that we saw it much more commonly than any other level. So we actually started looking this up, and we found we had stopped at T10 in about half the patients, and T11, T12, L1 in another half of the patients. So we actually broke them up into T10 and thoracolumbar and started to look at whether T10 was truly an issue or not an issue or what. And so we looked at 365 patients, 119 with acute proximal junctional failure. Mean age of the group was 66 years, and mean follow-up was 40 months almost. And we had much more acute proximal junctional failure, actually, statistically significant, in the T10 group than in the other group. So we're scratching our heads, why T10? You know, we thought maybe T12 was a dangerous level. We grew up thinking we shouldn't stop at the thoracolumbar junction, but in fact, if you really think about the thoracolumbar junction, T10 is the first attached rib. So maybe T10 is the one we're not supposed to stop at. We just thought because there's a T11 and a T12 that it was one of those two. Or maybe the group was different, and I actually think probably that's the reason. The group that we often stopped at T11 or T12 or L1, we could get away with it. We were fixing something a little differently, or we were fixing a different problem than the group we stopped at T10. We stopped at T10 because we didn't want to go up to T3 or T4, and we should have. And so that is, in fact, the case. There was more sagittal imbalance in the group we stopped at T10 than the group that we stopped lower. And we fixed the sagittal imbalance better in the group that we stopped at T10 than in the group we went lower. So they had more balance problems, and we fixed it better, and then we got more proximal junctional failure in that group. And so it kind of fit everything else that we've seen in the literature. And then lastly, we wanted to look, because we thought, well, okay, if we can't stop at T10 or T11 or T12 really, should we just go up to the upper thoracic spine all the time? Why not just go up to the top and deal with it? And we can kind of spread our screws out so it's not too much bigger of an expense, but we thought maybe that would save us the problem. So we didn't do this prospectively. Unfortunately, it's all still retrospective, but we said, well, let's see if our experience bears that out. So we looked at separating 216 patients that we had done where we had either stopped in the upper thoracic spine or lower thoracic spine and saw what the complications and risk profile was and whether we revised those patients more commonly. And in fact, the patients where we went to the upper thoracic spine had worse sagittal imbalance numbers. Pelvic incidence was higher, thoracic kyphosis was larger, the plumb line was more abnormal, and global sagittal alignment was worse. And despite that, we saw less proximal junctional failure when we went to the upper thoracic spine. The problem was we saw a greater non-union rate. And so we essentially traded one complication for another, and our revision rate, early revision rate and long-term revision rate, was almost identical for the two groups. But it was for two different problems. In the low thoracic spine, our early revision rate was a mechanical problem, proximal junctional failure. In our upper thoracic spine group, it was a biological problem, a non-union. And frankly, looking back on it, I think we could fix our biological problem more easily than I think we can fix our mechanical problem. So going forward, it'd be easier to fix the non-union problem of upper thoracic spine stopping point with biological solutions than the fact that we don't really have a good mechanical solution yet for stopping the low thoracic spine. But that's what this data showed us. Essentially, the revision rate's the same, but it was for APJF in the low thoracic spine, it was for pseudoarthrosis in the upper thoracic spine. That's whether we looked at acute revisions or overall revisions over a period of 4 years, 5 years, or we looked at survival analysis. Again, this is 2-year survival analysis of stopping point in the low thoracic versus upper thoracic. This is the 5-year, essentially the same. This is the 10-year survival analysis of those two groups. So I'm going to go through one more case and then kind of bring this to a close with a few lessons learned. 74-year-old woman sent to us clearly out of harmony to L1-2 and L4-5 non-union, severe low back pain and neurogenic claudication, some imbalance with an attempt at her standing up straight by using retroversion of the pelvis. And this is what she looks like on CT scan, and we can see loose screws and degenerative changes. She also has L5 radiculopathies. And so we plan to revise this above and below. She had every risk factor for proximal junctional failure. We decided to stop at T10 because the proximal junctional angle was 0 degrees at that level. By some of our data, that's a safe level to stop at. Of course, she's got other reasons to develop proximal junctional kyphus and or proximal junctional failure. There's our early postoperative film that we are proud of. Of course, she already has a PJ of 8 degrees. It was 0 degrees pre-op, and now all of a sudden it's 8 degrees. I'm not sure why that is. Maybe she's just standing forward now that her pelvis is in better alignment. And this is what it looks like 6 weeks later with 37-degree PJA. And this is what it looks like 9 months later with a 53-degree proximal junctional angle and some developing early myelopathic symptoms. So we took her back and fixed her in line and quad rod construct, and she did great initially. This looks good. That didn't. She developed some, again, progressive myelopathy at the top of the construct with a PJ, proximal junctional kyphosis and failure, and ultimately had a revision again up into the cervical spine. And this is now 3 years since that surgery, and she's remained stable and not myelopathic. So, techniques for proximal junctional failure, decreasing the risk of this. What seems to help? This is level 5 evidence at best. There's a lot of level 5 evidence in the literature. There's not much more than that. So my level 5 evidence to you, don't end the construct in lordosis. Try to take your instrumentation up to a point where you are creating the beginning of kyphosis so that you don't get a rigid lordotic segment that then the patient kyphs above. Begin or constitute thoracic kyphosis at the top of the level is essentially the same thing. Watch out for a flexible thoracic kyphosis preoperatively. They are standing as straight as they can when you tell them to stand up straight for this initial Scoli film. They may have 0 thoracic kyphosis. As soon as you fix the lower part of their spine, they develop a thoracic kyphosis that may throw their shoulders forward and a lot of weight on their proximal junctional angle. So watch out for a flexible thoracic kyphosis pre-op, and don't fully correct to a young adult lumbar lordosis or sagittal balance. So I used to aim for 5 centimeters or less of sagittal vertical axis. I don't aim for that anymore. I'm aiming for under 10, but not, so I'm aiming for good, but not great. Avoid overly rigid constructs. I've used a lot of chrome cobalt rods in my day, and I think they're great for having to do in situ bending once I've got the rod in place, because I feel like with titanium, if I'm bending it once the rod's in place, I'm cracking it. I don't know. I don't like the bending and rebending titanium rods, but I think they're too rigid for most adult spines. Stay low in the lumbar spine when possible. Go to the upper thoracic spine, use biologics, decrease non-union rate when needed. And that's sort of the lessons learned. I want to just also go through what I've read in the literature that seems to be what somebody else's homegrown level 5 evidence is. I've heard it a lot. I've tried some of it. Some of it doesn't work. I go back and forth between whether I think this is a great idea, and I have a list of them. Hooks at the proximal end of the construct. I loved them, then I hated them, then I loved them, then I hated them. I'm currently in a I use them more phase of this sinusoidal curve again, but I have little faith that it really solves the problem. Cement in the upper instrumental vertebrae or the UIV +1. Some people are complete believers in this. I've tried it. I've seen failures. I've had failures sent into me. I'm not a big believer in it. Some people are, and that's great. I applaud you if you are, but I just have not felt like it worked. Spinous process wiring, spinous process clamps at the top of the construct, or Merceline tape, maybe. It may help that ligamentous proximal junctional kyphosis, but I don't think it helps prevent the failure mode. At least I haven't seen literature really support that yet. Dynamic stabilization at the top of the construct, or MIS at the top of the construct, somehow or not, hopefully de-innervating the muscles at the top of the construct if we do most of this open. Maybe, again, very little literature to convince me yet that this is going to work, although I'd be hopeful if I saw more. Less rigid fixation, more rigid fixation, chrome cobalt rods, titanium rods, stainless steel rods. I'm not sure. I'm a little more comfortable with the hooks and the cement maybe than the others on the list, but again, I'm not sure I really have confidence that this has been sorted out yet. So with that, I'll just summarize again. The incidence of proximal junctional kyphosis is about 17 to 39% in adult deformity patient population. Very common, particularly in the low thoracic spine, when the upper instrumental vertebrae is in the low thoracic spine. Incidence of PJF is about the same, 6 to 30%. It's a little bit tighter definition of fracture, hardware failure, and or myelopathy at the top of the construct. Timing occurrence, 60% within the first 8 weeks, 75% within the first 2 years. PJK seems not to affect the quality of life measures that we use, but proximal junctional failure does. And so I think it's actually more important to diagnosis because it does affect quality of life measures, more important than just the PJK diagnosis. High incidence of acute proximal junctional failure in adult deformity patients older than 55, especially if the upper instrumental vertebrae is in the thoracolumbar spine, and especially if they're sagittally imbalanced preoperatively. Myelopathy commonly leads to a need for revision. Thoracolumbar proximal junctional failure, commonly upper instrumental vertebrae or UIV +1 fracture. And if it's a UIV +1 fracture, we'll often see this listhesis that goes along with it. The upper thoracic PJF commonly associated with spondylolisthesis also. Lastly, recognize the risk factors. A patient who is osteoporotic, who is older than the age of 55, if they've had anterior and posterior surgery, particularly if they've been fused to the pelvis. It's far more common. I didn't mention some of our data on this, but it's far more common if they've been fused to the pelvis than if not. And if they're sagittally imbalanced, and we change that significantly. Prevention, we should all be working on this. Thank you.